Navina, I think we can start.
Yes, sir. Good evening, everyone. Welcome to the first journal club of this year, 2024. Today we'll be going through AKI Vex study, that is the venous excess ultrasound score in the management of patients with AKI in the ICU. To take us through, we have our speaker, Dr. Malathi from Royal Care Super Speciality Hospitals, Coimbatore. We have the mentor, Dr. Vivekanandan sir from Royal Care Super Speciality Hospitals, and I welcome our academic directors of HICS, Dr. Gansham sir and Dr. Srinivas Samvedam sir. Malathi, over to you.
Good evening to everyone. So I am Dr. Malathi, doing second year DR&MA in Royal Care Super Specialty Hospital at Coimbatore. Today I am going to present the journal on Vexas score in the management of patients with acute kidney injury in the intensive care unit. It's an Akivex study. This journal was published in the American Institute of Ultrasound in Medicine in the year of 2023. So I am going to discuss under these headings: concept, aim, methodology, statistical analysis, results, discussion, and conclusion. So this study mainly focuses on the cause of venous congestion in the acute kidney injury and how these congestion will be evaluated by using the Vexas score. So a few points about acute kidney injury. Acute kidney injury is one of the most common complication of critically ill patients. Its incidence varies from 30 to 60%, of which 10 to 20% of patients will require renal replacement therapy. The mortality varies up to 50%. So there are various etiology and pathophysiology attributed to the development of acute kidney injury. Among these etiologies, venous congestion is attributed to the development of acute kidney injury. So we are going to discuss how venous congestion will lead to the development of acute kidney injury. So congestive nephropathy is a recent term. It is a reversible subtype of renal dysfunction.
Dr. Malathi, can you please check your audio?
Yes, ma'am. Are you audible?
Please go on.
Yes, ma'am. So congestive nephropathy is a recent term. It is a reversible subtype of renal dysfunction. It is associated with declining renal venous outflow and progressively increasing renal interstitial pressure. So in this slide, I am going to explain how increasing central venous congestion lead to the acute kidney injury. So if patients having higher central venous congestion, that will directly reflects to the venous congestion in other organs, including renal veins. So once there is an increase in venous congestion, it is initially compensated by increased renal interstitial pressure and also increase in lymphatic outflow. Because renal is an encapsulated organ like compartment syndrome, after a particular point, this venous congestion leads to the increase in pressure in the afferent arterioles. Thereby, it reflects increase in the pressure in the afferent arteriole. Thereby, it reduces the pressure difference between afferent and efferent arteriole. Thereby, it reduces the GFR and thereby it reduces the urine output. So, the increase in venous congestion, it's directly lead to the development of the acute kidney injury. So, if we identify patients at risk of these type of patients by using Vexas score, help in identifying the patients and also to treatment. How Vexas score will help these findings to identify these patients. Vexas score incorporates venous congestion assessment in the 4 veins. It is a venous excess ultrasound. So in this scoring system, 4 veins are assessed. First one is inferior vena cava. Next is hepatic veins. Next portal vein and renal veins. So first we have to assess the inferior vena cava. Once we will assess the inferior vena cava, if its diameter is less than 2 centimeter, it is graded under 0, then there is no further assessment needed. If its diameter is more than or equal to 2 centimeter, we have to proceed to the next step 2, that is assessing the hepatic vein. Once we identify the hepatic vein, we have to put the Doppler mode. In this Doppler mode, normally it will look like this pattern, that is systolic waveform will be greater than the diastolic waveform. If patient is having mild abnormality, that is mild venous congestion, there is a systolic waveform will be lesser than the diastolic waveform. If patient is having severe abnormality, there is a reversal of systolic and diastolic will occur. Likewise, we have to assess the portal vein. After identifying the portal vein, we have to put the Doppler mode. In portal vein, there is a monophasic waveform with little variability will occur in normal patients. In this type of Doppler, we have to measure the maximum diameter and minimum diameter. And by using the pulsality index formula, that is V max minus V minimum divided by V max, it will give the pulsality index. This normal index is less than 30%. If patient is having mild abnormality, the index varies between 30 to 49. If a patient is having severe abnormality, the index goes more than 50%. After assessing the portal vein, next we have to assess the renal veins. In renal veins, once we identify the renal veins, we have to put the Doppler mode, and then we have to assess the renal vein pattern. Normally, it is a continuous flow pattern. In a mild abnormality, there is a discontinuous biphasic flow with systolic and diastolic phases. In severe abnormality, there is a monophasic flow with only diastolic phase occur. So after assessing these parameters, we will grade according to these findings. Patient are graded 1 if patient is having IVC greater than or equal to 2 centimeter and any compo of normal or mild abnormal patterns. If patient is graded 2 if patient is having IVC of greater than 2 and 1 severe abnormal pattern. And
Dr. Malati, Dr. interrupt you. Dr. Malati?
Sir? Sir, I am audible? Sir? Sir? Am I audible?
Yes, Malati, you are audible.
Okay, sir. Shall I proceed?
Yes.
Yes, sir. So if patient is having IVC is greater than 2 and if they are having more than 2 abnormality patterns in other 3 ways, they are come under the grade 3. So these are the basic concept used in this study. So for this is the study which will give the association of Vexas scoring with the identification of AKI. And this study is conducted by Bharatwaj et al. In the cardiorenal patients. They told combination of the Vexas scoring system demonstrated there is a reduction in Vexas score is associated with AKI improvement. So by this background of these studies, they proceeded with their study. But all these studies are conducted in the cardiorenal patients, not in a general population patients in the ICU. So their aim of the study is to verify whether the Vexas score can serve as a guide to decongestion in patients with a severe AKI and whether the modification of the score can be associated with an increase in the number of renal replacement therapy free days in 28 days. They conducted this was an experimental study. It was conducted in Hospital de Clínicas de Porto Alegre in Brazil from January 2021 to January 2022. They included patients with age more than or equal to 18 years, patients who admitted non-electively in ICU, and who developed severe AKI. AKI was graded according to the Kenya-ECO criteria. And coming to the exclusion criteria, patients with a life-threatening indication of renal replacement therapy at enrollment or they required renal replacement therapy before the recruitment and known CKD and the lack of commitment to provide a renal replacement as part of the limitation of ongoing life support and who uses the ECMO or the patient who had diagnosis of hepatic cirrhosis or other condition with portal hypertension or post-renal causes of AKI were excluded from their study. So, considering the statistical analysis, the sample size needed for this study is 84 patients, but they included 90 patients in their study. Coming to the study protocol. So, after the enrollment, patients underwent Vexas scoring at the 6 hours up to 6 hours of enrollment and after the 48 hours. So, 2 times Vexas score was assessed. After the first assessment, the patients were graded according to the Vexas scoring system, and the intervention was suggested to the attending physician the use of diuretic in patients with Vexas score more than 1 at enrollment. But for the use and type of diuretics was not specified and not protocolized. The next, coming to the ultrasound assessment, how they assessed. So first they are assessing the inferior vena cava. The inferior vena cava was assessed from the joining of hepatic vein 2 centimeter from this, and it was the diameter was measured at the end of expiratory phase. If the diameter is less than 2, the patient was classified as Vexas 0. If the diameter was more than 2, then the hepatic vein Doppler and portal vein Doppler were evaluated. In the study, they did not include the renal vein Doppler as in the original Vexas score. So as previously explained, hepatic vein Doppler was assessed and they were graded as either they are having mild abnormality or severe abnormality. And likewise, portal vein also assessed and they also graded according to their pulsatility fraction index, like as mild abnormality or having severe abnormality. So according to this scoring, they were graded as either Vexas 0, 1, 2, 3. This 0 indicates if patient is having IVC of less than 2 centimeter, and if graded as 1, if IVC is more than or equal to 2 with normal Doppler pattern. Only IVC is greater than 2. In Vexas 2, patient is having IVC more than 2 with either one vein has showing mild abnormality. And if patient is greater under 3, if their IVC is greater than 2, with either hepatic vein or portal vein showed the severe abnormality. Any one is showing greater severe abnormality, they are come under the Vexas score of 3. So after assessing this first initial Vexas scoring system, these were assessed by only 2 persons. That is MFR and MMP. These are the 2 persons. They independently assessed and recorded the images. So they are blinded to any other clinical data or outcomes. So they, if any disagreements were there, it would be discussed between them and scoring will be given. After their scoring, it was given to the admitting physician for the use of diuretics. And apart from these Vexas score, these are the parameters also obtained: demographic and baseline clinical data, and common variables used to assess fluid overload in the ICU, such as fetal edema, weight variation from ICU admission to enrollment, CVP at the enrollment, fluid balance 24 hours before enrollment, cumulative fluid balance from ICU admission to enrollment, and fluid overload percentage, which was calculated by using this formula, that is total fluid input from ICU admission to enrollment minus total fluid output from ICU admission to enrollment divided by admission body weight into 100. So the primary outcome, how they are used is RRT free days and no RRT free days. So RRT free days is defined as the number of alive and free from renal replacement therapy. Patient discharged from the hospital before 28 days were considered alive and free from renal replacement therapy at day 28. So non-survivors at day 28 were considered to have a no RRT 3 days. So these are the variables used as secondary outcomes. That is 28-day RRT use, KDICO-AKI staging improvement, that is reducing the KDICO category, fluid balance from enrollment to 48 hours, ICU mortality, in-hospital mortality, length of ICU, and hospital stay. So these data were collected using data extraction, manual and electronic health records, and outcome were collected after the Doppler waveform interpretation and the classification of Vexas score of all patients. So these are the statistics used to analyze these papers. That is, continuous variables were expressed as mean standard variation, categorical variables presented as frequencies and proportions, and a Fisher exact test was applied to categorical variables. So the statistical significance was set at 0.05. So next, coming to the results. So totally 155 patients were enrolled. So after excluding, according to the exclusion criteria, 91 patients were included, but one patient have the poor ultrasound images, so that patients were excluded. Finally, 90 patients were included in their study. So these are the baseline characteristics of the patients in their study. So all the parameters except patient on admission, patient had a sepsis. That is, after the assessment, patients were divided into two groups. Whether patient is having Vexas score of less than or equal to 1 at enrollment, and the patient who are having Vexas score more than 1 at enrollment. So totally 54 patients were had the Vexas score of less than or equal to 1. Totally 36 patients had Vexas score of more 1 at enrollment. So among these groups, only sepsis, the high number of patients having Vexas score of sepsis patients having less than 1 group. Whereas patients who whereas patients who required mechanical ventilation.
Somebody is actually speaking. Can you mute that whoever is there?
Whereas patients who required mechanical ventilation had a higher number of patients had a Vexas score more than 1 group. Whereas the commonly used variables such as pedal edema, fluid balance, CVP, in these variables, there is no difference between these two groups, which indicates what commonly we used fluid assessment in the ICU did not vary between these two groups. So next, coming to the primary and secondary outcome. These outcomes were dependent upon the patient who did not reduce the Vexas score and patient who reduced the Vexas score. So accordingly, they given these outcomes. So patients who reduced the Vexas scoring had the higher number of RRT free days and also staging improvement and mortality reduction in hospital mortality reduction. So patients who reduced the Vexas score has more number of RRT free days and staging improvement and in hospital mortality. And whereas patients with Vexas more than 1, they analyzed within that group. This group of patients does not have any significant and improvement in RRT. So this is the Sankey diagram. It has the nodes and arcs. It connects from one variable to another variable and how patients will flow from one variable to another variable. In this, we have blue node and this is the orange node. It indicates, blue node indicates patients who have the Vexas of more than 1 at enrollment. And orange node will denote Vexas less than 1 at enrollment. Here this black, it denotes the reduced the Vexas score, and this green it indicates the same or increased the Vexas score. And this violet will denote the did not use the RRT, whereas this denotes the use the RRT. So this height and width denotes the proportion of patients. So patients who had a Vexas score more at enrollment, majority of the patients will have the reduced the Vexas score. So among the patients who reduced the Vexas score did not require the RRT. So this diagram will indicate Vexas score more at enrollment who reduced the Vexas score did not use the RRT. Whereas patients who had Vexas less than or equal to 1 at enrollment, majority of patients did not reduce, they have same or increased Vexas score, and among these patients, majority of patients use the RRT. This A indicates all 90 patients. Whereas in this diagram, they excluded patients who had Vexas at 0 and they included only Vexas 1 at enrollment and Vexas more than 1 at enrollment. In this also, they have majority of patients flow from flow towards the reduced Vexas score. Among those patients, they did not require the RRT. So this diagram indicates patients who reduced the Vexas score is required less number of RRT, whereas patient did not reduce the Vexas score required more number of RRT. So coming to the Vexas score versus diuretics. So patients with a higher score of Vexas and enrollment received more loop diuretics in the following 48 hours. The furosemide dose used in this period also showed a significant difference with 100 milligram, that is 5 to 85 milligram in the Vexas score more than 1 group, and 0 to 85 milligram in the Vexas score less than 1 group. So it indicates a higher dose of diuretics was used in the higher scoring system. Next, coming to the discussion. So in their study, they concluded they had higher number of diuretic use in patients with a higher Vexas score, and also patients who reduced the score in 48 hours had more RRT free days at day 28 than patients who did not reduce the Vexas score. Bharadwaj et al. Found that the reduction in venous congestion was associated with an improvement in renal function in an observational study. So their finding correlate with their study, in this type of study. And the variables commonly used to identify patients with venous congestion, such as central venous pressure, fluid balance, peripheral edema, weight gain, were not different between the groups with Vexas less than or equal to 1 and more than 1. It is a similar finding. It's evidenced by Bharadwaj et al. So the prevalence of AKI due to the venous congestion in critically ill patient is unknown. Yes, there is no epidemiological study has ever reported this study. In our sample of patients with a severe AKI in a general ICU, approximately 40% had a Vexas score more than 1 at enrollment. A higher prevalence of sepsis in the Vexas less than or equal to enrollment group indicates the sepsis is the leading cause of AKI in this group of patients, whereas more patients on mechanical ventilation in the group of patients with Vexas more at enrollment indicates either venous congestion leads to the mechanical ventilation, or else if patient is already on mechanical ventilation, that may reflect as patient is having Vexas more than 1. So this study was conducted in critically ill patients from a general ICU, unlike the original Vexas study, in which non-critical cardiac surgery post-operative patients were included. They did not include the assessment of intrarenal vein Doppler, similar to these two studies, Guys et al. And Bharadwaj et al. Studies. So these two studies already I quoted in initial itself. These studies were conducted in the cardiac surgery population. So first study, their result denotes there is an association between the Vexas score and subsequent development of AKI. Bharadwaj et al. They told there was a significant association between changes in Vexas grade and fluid balance. So coming to the limitation, this study is a single center study that included only a small number of patients. They did not include a control group. They did not provide a protocol for diuretic therapy. Only 2 investigators performed all Vexas scans. It also limits generalizability. So to conclude, a higher diuretic use in patients with a higher Vexas score they found, and patients who reduced the Vexas score in 48 hours had significantly more RRT free days in 28 days when comparing with those who did not reduce the score. The impact of incorporating the Vexas score to guide fluid management in critically ill patients with AKI should be evaluated in future trials. Thank you.
Thank you. Thank you, Dr. Malati. This is Dr. Vivek from Royal Care.
Thank you, Dr. Malati.
Hospital.
Thank you, ma'am.
Hello.
Hello.
I would like to take comments from Dr. Vivek, sir, regarding this study.
Yeah. Thank you. Thank you, Dr. Naveena. I just wanted to go back a step and then we could discuss a little bit more about this article. I think AKI per se has got a high incidence in our ICUs. We all know that. And the associated mortality is also very high. And the key thing with AKI is the heterogeneous nature. It's a heterogeneous entity which has got a diverse pathophysiology. So what we are talking about is the congestive nephropathy. So the congestive nephropathy has got a huge role in AKI.
Sir, your audio is not very clear.
Okay. All right.
Naveena, we could hear Vivek.
Oh, okay. All right. I'll shout
Hello?
a little bit more. I'll shout a little bit more.
You're okay. You're okay.
So I think since 1931 onwards, I think the animal studies did suggest that the venous pressure, if it were to increase, then the interstitial hydrostatic pressure also increases. And the kidney, being an encapsulated organ, just tends to compensate by increasing the lymphatic flow and make things better. But unfortunately, after a certain threshold, then the venous outflow is also going to reduce, the lymphatic outflow is going to reduce, and there is going to be a decompensation causing a reduced renal blood flow. So the arterial flow will also reduce, and GFR eventually will reduce. So the congestive nephropathy is an entity that is very well proven that it can cause a spectrum of AKI. So how much is the incidence? So some of the recent studies are quoting somewhere around 40% of AKIs in critically ill patients could be due to this entity, congestive nephropathy. So how are we going to assess? There are no gold standards yet, but we could have these abnormal Doppler flow patterns on the hepatic veins, the IVC distance, IVC being more than 2 centimeters to start with, then looking at some of the splanchnic circulations. So that could include the hepatic vein, portal vein, and the intrarenal veins as well. So that is where the Vexas score came in, and from the focus, there are suggestions of use of Vexas score. Vexas score has been previously validated in cardiac patients, post-cardiac surgery patients, patients with cardiorenal syndrome. So quite a few articles, like Dr. Malathi said before, they have studied NF. So not a huge data on it, but there are studies to suggest in those population, Vexas scoring will suggest the congestion, and if the congestion can be reduced with improvement of Vexas scoring using diuretics, then probably the need for RRT can be reduced. So from there, that is where the current study that we are discussing, the AKI-VEX study, has come into place, and the Brazilian group, they have intervened with their intervention that whenever the Vexas score goes more than 1, then there was a suggestion for the clinician to use diuretic. And then when they use the diuretic and then the scoring reduced, the Vexas score reduced, then the need for RRT came down dramatically. So it is a significant reduction that they quoted. So I think it is a start. So I think going back to volume overload state, I think we'll discuss further. Maybe I'll stop here, and then we'll take some queries, suggestions, points, and then we'll discuss further.
Navina, you can ask me. I think we lost your audio, Navina.
Any thoughts? Anybody wants to make any comments?
I have a few things to tell, sir. First
Yes,
of all, the study, the Vexas score that is used in study does not include the renal vein Doppler. So that's one modification, which probably could have been because it's difficult to actually obtain the views of the renal vein Doppler in the ICU patients. And the other thing that I felt was there are 2 people only doing the studies, which probably reduces the inter-observer variability. And when you see the basics in this article, I found that the cumulative balance was much higher in the patients with Vexas score of less than or equal to 1 compared to the one with a Vexas of more than 1. That was one thing that was a little strange for me. And other thing is that they did not include patients who had AKI at admission directly. So I would like to take comments from Samvedam sir regarding this study and his practice.
Yeah, Navina. The reason why AKI, can you hear me?
Srinivas, your volume is low. Your volume is low.
Sir?
Is it
Yes,
better
sir.
now?
Yeah.
Yes.
Is it better?
Yes, Dr. Srinivas.
Yeah. So the reason why AKI has been excluded from the study is the purpose of doing this study is to establish whether isolated volume overload, irrespective of other etiologies, can determine AKI and the need for RRT. So if an AKI has happened as a result of, for example, sepsis, or as a result of pancreatitis, or as a result of burns, for example, or trauma, for example, or postpartum headache, for example, you can't attribute only the positive fluid balance to the genesis of AKI. While we know that hypovolemia can produce pre-renal AKI, hypervolemia and volume overload causes AKI by renal causes. That means it causes renal venous hypertension, renal congestion, and therefore it causes acute kidney injury. So that was the hypothesis. Having said that, and the reason why renal venous Doppler has not been included is that again, we need to,
So
as
your
if you
audio
understand
is
the
not clear, so we are not able to hear you.
No? Can you hear me now?
We could
Just give
hear
me 1
you,
minute.
just that the volume is on the lower side.
Just give me 1 minute.
Srinivas, sir?
Can you hear me now?
Yeah,
Yes, better, sir.
Is it better now?
lot
Yes, sir.
better.
Yeah. So
Can we begin it
the
again?
reason, yeah. So you begin at the beginning. Okay. So so okay. The reason why AKI was not included in this comparison is that the hypothesis is that isolated positive fluid balance is itself an etiological factor in the genesis of AKI. So if you had AKI happening because of another factor like a sepsis, a pancreatitis, a postpartum hemorrhage, or a trauma, then demonstrating volume overload with a Vexas scan and then saying it is the you can't actually establish a cause and effect relationship for the volume overload. So that's been the hype. That is the logic behind this study. That's also the logic of limiting it only to hepatic venous assessment, because what we are saying is if you pick up Vexas scores in stage 1 and stage 2, that means before the renal veins get congested, even then it is a risk factor for AKI. That is the purpose of this study. So while we all say that IVC diameter and IVC diameter of more than 20 millimeters is venous congestion, it's not enough to just measure a diameter and then say it is venous overload. You need to look at the phasic variation in the trace, in the Doppler, which will tell you whether the pressures within those systems are actually high. So if you have a pressure reversal that is happening in the hepatic portal vein and the hepatic vein, you need not have renal venous congestion. That level of that degree of volume overload is itself enough to cause that actually causes a triggering of the renin-angiotensin aldosterone axis. It causes a relative hypovolemia in the kidneys, and then you develop AKI. That is the purpose. No, it's a new, and the reason why I feel only two operators did the Vexas scan, which is being quoted as a limitation of the study. I would see it as a strength of the study. The reason being, Vexas scan is a technically challenging skill. It's not like assessing the IVC diameter or looking at the ejection fraction or looking at TAPSE or looking at jugular pressure and or doing a venous cannulation with ultrasound or doing a nerve block with ultrasound. You need to precisely identify the vein and try to establish the signal at the exact point and assess the Doppler. And getting a good signal of the hepatic veins is equally difficult. Of course, the most difficult is the renal venous Doppler. So, if a technically skilled person is doing it, the reliability of the findings becomes stronger. So that is the reason why I think they did it. They limited it to two experienced operators who are trained in Vexas. So if I have a semi-skilled person doing a Vexas and then a very skilled person doing a Vexas, and then I compare the results of these two and put them in the same data set, there is skewing of data. There is bias because you are somebody may be over interpreting or under interpreting versus somebody who is correctly interpreting. So that's the reason. But um, what is my practice? You see, if a patient has received more than 3 liters of fluid, or the holy grail of 30 mils per kilogram body weight of fluid, and still oliguric, somebody says, I want to give more fluid. Yes, we all apply the principles of dynamic indices of fluid responsiveness. But if somebody is fluid responsive, it doesn't mean he will respond to fluids. It doesn't mean he requires fluids. Now, if somebody who is hypervolemic also shows up on the Vexas scan as a hypervolemic patient, I would not give him fluids irrespective of what the dynamic indices are saying, because the number of caveats which the dynamic indices of fluid responsiveness have are too many in a critically ill patient, including your respiratory rate, your PEEP, your intra-abdominal compliance. But my only concern with the whole Vexus syndrome or the Vexus concept is that it stops you from progressing further if the patient's IVC is less than 2 centimeters in diameter. Now, that's a major challenge in a patient with a compartment syndrome. If somebody has a pancreatitis, for example, because of the intra-abdominal pressure, the IVC may be collapsed, may be compressed at this point where you are assessing the IVC. So, if I get a 1.8 centimeter IVC and patient is volume overloaded, and I don't put the patient under the Vexus protocol because the IVC is less than 2 centimeters, I am missing a big problem. That is my concern. So I personally believe that if you want to do a Vexus scan, you do the IVC diameter. If your IVC is more than 2, anyway you will do the Vexus. But even if the IVC is between 1.5 to 1.8, at least look at the portal vein. If the portal vein is looking okay, it's not showing phasic reversal, then you can say my patient is not volume overloaded. So don't just make a judgment on the volume status of the patient on the Vexus scan. If the IVC is between 1.5 to 2, don't stop there. If your suspicion and your fluid chart review, your intake output balance review shows a positive fluid balance, then please make sure you look at some other vessel, preferably the second one in the list, that is the portal vein, and then only make a judgment that this is not venous hypertension. This is not fluid overload. That's my practice.
Srinivas,
Yeah, Gansham.
yeah, this is both Vivek and Srinivas, your thoughts. See, we all understand and agree to the idea that today, positive fluid balance is associated with poor outcomes, and with the concept of not just looking at the mean arterial pressures, but looking at the organ perfusion pressure in the context where you look at the venous congestion. And because we are not able to measure the venous end of each organ, extrapolating the CVP to be on the other side, can we start see clinically when we look at or coming to a decision of whether the patient is fluid overloaded, we either rely on the input output balance or we clinically look at signs of overload. Many a times these could be, either we miss the fluid overload part, or by the time the clinical signs develop, it is already too late. So do you see Vexas as one of the complementary uh, parts which can also help us identify in general, not just with respect to kidney, but in general as a fluid overload state? And
Yeah, Gansham, I want to look at it in two ways. One, Vexus is a audit tool, in the audit of your practice. If I give 3 liters of fluid to somebody and patient becomes still persistently oliguric, before I give him more fluid, maybe a Vexus Vexus is the solution. Secondly, I would like to in a patient who has ARDS, for example, who is being ventilated with moderate to high PEEP. I would actually like to combine the Vexus scan with the assessment of the RV, because what is good for the RV is not good for the kidney. So if I am trying to look at such a complex patient, I should have two modalities. One that is looking downstream at the the hepatic, the portal hepatic and the renal veins, and upstream at the right ventricular compliance, at TAPC, for example.
Okay. Just wanted to mention this. I think going back to Dr. Naveena's comment, that patients who did not have a Vexus score more than 1, even those patients had this clinically measured parameters of volume overload on the higher side. That is exactly the problem. So the clinical measurements, all those parameters, what is mentioned in the article, does not relate to patients having a Vexas score more than 1 or less than 1. So there is no correlation at all. So all these parameters does not fit in or relate to volume excess. So they are poor indicators. So we don't have a magic tool of this particular parameter is going to tell us that there is going to be a volume excess. So that is the problem. So I agree with Dr. Srinivas that this is a light single tool looking at Vexas scoring that will tell you only a small problem. But being AK being a heterogeneous entity, there are so many other reasons. So all those things should be individually be identified. So we need to have different tools for each one of those sub-phenotypes, and only then I think we can target all those problems. So I don't think there is any magic bullet to identify volume overload. That is what I wanted to say to Dr. Ghanshyam. Of course, one validated thing is this magic number where they say more than 10% volume overload. I think it was that Picard study. I think they came up with this validation of 10% volume overload.
Yeah,
10% volume overload as an indicator of AK development. So we could measure the summation of volume overload status over 3 days, and then come up with this number if it is more than 10%, which has got this formula: intake over 3 days minus output over 3 days divided by the ideal body weight on admission times 100. And that will give a percentage. And based on that percentage, if it is more than 10, that could be a surrogate of volume overload. So that's all we know as of now.
Yeah, Navina, I would like to add one more point to this analogy. See, just as when you have patients who are on mechanical ventilator and you try to increase the PEEP and try to optimize the driving pressure, you can actually look at the lung ultrasound and see whether the B profile is resolving from SCE to B2 to B1 profile, which means the lung is getting more compliant. Now, the same thing happens with patients on whom you have started fluid removal, right? Now, what happens is when you start patients on CRRT, for example, and you have a 50 ml per hour negative balance on these patients and his mean arterial pressure drops, our first reaction to that patient is actually to stop the ultrafiltration or reduce the fluid removal on the CRRT. Now, before we do that, if you do a Vexas scan and then you understand that it is not the fluid removal which is actually causing the hypotension, then you look for other causes of hypotension. Otherwise, if you start with a Vexas score of 3 and it stays at 3 and you cut off the fluid removal, you are actually defeating the purpose of starting such patient on a CRRT. So I would actually use it more as a dynamic, continuous tool rather than one particular point of times tool to initiate RRT or initiate ultrafiltration. Right. Similarly, you have a lot of patients who have heart failure for whom by rote we write diuretic prescription, and sometimes we put them on diuretic infusion, although there is no evidence for it. But is that diuretic going to be beneficial for the cardiorenal syndrome, for example? You try to put them on diuretic infusion to decongest them, but is that decongestion working? How do you know? Right, your urea goes up. So when your urea goes up and your metabolic alkalosis comes in, you tend to cut down the diuretic dose. Is that the way to do it? Where is the objective evidence that your fluid excessive fluid has been removed? So I think in all these complex scenarios, Vexus is going to be the answer. But before it becomes the mainstay for fluid optimization in the ICU, the training has to be immaculate, because a lot of errors can creep into Vexus score much more than lung ultrasound and much more than IVC assessment, maybe much more than echocardiogram, if you ask me. So all ultrasound training programs which most societies and other professional bodies do should include. Unfortunately, what happens is you cannot demonstrate venous hypertension in a subject, in a volunteer. You can only demonstrate normal venous blood flow in the kidney, normal hepatic blood flow, normal portal venous blood flow. How it looks like when there is volume overload, you cannot see. And And normally in an ultrasound workshop, you pick out the leanest volunteer to get the best window. Now that's not what a critical care patient would be. A volume overloaded, edematous, hypoalbuminemic, supine patient is not the same as a volunteer who is 40 kilos and lean and you know. If you do Vexas score on me and Gansham, you will know the difference. How difficult it is to get the window.
There was no control group in this study, sir. So do you think there should have been a control group, placebo, or maybe they could have used CVP?
No.
Or do you think this study can redeem use of CVP for fluid overload, identifying fluid overload?
No, I don't think it can do, because a patient with a CVP of less than 4 can have venous hypertension. It depends, because the CVP is also dependent on your lung compliance. It's not that it's just you fill in the tank and the manometer goes up. It's not so simple. Maybe you see what happens is, if you want to give more fluids to a patient, or if you want to increase PEEP on a patient who is hypervolemic, if that increase in PEEP is actually causing a rise in CVP, that means your right ventricle is getting non-compliant to your upstream pressures. That is the concept we should talk about. PEEP will be, CVP will come into respiratory monitoring rather than hemodynamic monitoring. This is my understanding of the current role of CVP. It's a reflection of ventricular compliance. It is a reflection of ventricular interdependence, but it is because it has got to do with the upstream pressure which the right ventricle is facing. So if a patient's PEEP increases and you want to know whether you are doing a right ventricular protective strategy or not with your mechanical ventilation, there is no other simple tool better than a CVP. If your CVP goes up with an increase in PEEP, that means your patient's lung compliance, your RV is becoming a little too tired with your ventilatory strategies. That's where CVP comes in, not with the fluid overload at this point of time.
How about any other dynamic variables that you want to include with this?
See, if I find a patient who is negative on the Vexas score and I want to give him fluid, just because his Vexas 0, it doesn't mean I give fluid to the patient. He has to have some index which says that he is hypovolemic, like he should have a pulse pressure variation, a stroke volume variation, or a positive tidal volume challenge test. If a patient has one of these tests positive and he is scoring low on the Vexas score, and ultrasound wise it doesn't show a B profile, that is the right patient for me to be liberal with fluids. Otherwise, I need to go with a conservative fluid strategy. But the key is to keep assessing the venous pressures quite more often.
Just to add a little to that, Navina, to whatever Srinivas said, apart from
Yes.
this, I think you also need to have a clinical context where there is evidence of shock or hypoperfusion. If the patient is not in shock, if the patient does not have any hemodynamic instability or evidence of organ hypoperfusion, then even if your dynamic indices or your Vexas is indicative of low volume, I don't think there is any need to give fluid.
Yeah, I think this should actually trigger a research question for any of the DRNB students who are actually listening to this presentation. It is a comparison of Vexas score versus lung ultrasound, and if you have electrical impedance tomography, you can compare these three things and actually identify which is the tool that actually, and maybe look at the TAPC and then identify which is the tool which actually identifies positive fluid balance. Of course, no substitute to a meticulous chart review, but that's the least often done thing. So if somebody wants to do a good study, I think a comparison of lung ultrasound, Vexas score, electrical impedance tomography will be a good, robust study. And if it's a multi-center study in India, the numbers will be phenomenal. I think it's just a research question that cropped up.
Plethysmography, you mean?
Plethysmography. Yeah. Electrical impedance.
Yes, sir.
Electrical impedance.
Vivek, sir, your comments on this?
Thoracic impedance, what I meant.
No, I agree with that. We are trying to tease out where exactly the problem is. I think, is it global or is it regional, pertaining to just the renal perfusion? So I think all of those different etiologies has to be teased out, and only then you can come to a conclusion what you're going to target at. So it could be a right heart which is failing, or it could be a congestion only in the lungs, not necessarily in the kidneys. And if you're going to tease out only the congestion is in the kidneys, then that would be ideal, which you can target at. The classical example that was mentioned by Dr. Srinivas to start with is the patient with increased intra-abdominal pressure. So that's typical. IVC will be low, and we haven't got that cohort in this study at all. No other study either. So that cohort will be missed totally. Yeah. Sorry, your question.
Would you put this study into practice in the ICU?
I think the relevance is, I think we have to take the positive side of it. So number one, this entity of congestive nephropathy. So I have to find out who are those patients who have got this congestion with the score. So I would definitely start looking at scoring these patients. And then at least this one entity has to be ruled out whenever you come across a patient with acute kidney injury. So that would be the practice I would do. That I would start scoring patients, tease out this particular entity. Apart from looking at IVC, IVC is something that you do routinely for all patients. So that can be part of the Vexas score. But that alone will not try to isolate certain patients where I'm going to do Vexas scoring. So I think Vexas will be on its own, will have its own merits, trying to see which patients have got higher score. And then, like Dr. Gansham or Dr. Srinivas was saying, look at other parameters like right heart failure, lung ultrasound to see the congestion, and then the volume status of the patient per se. So putting everything together, then you can target the renal inflow, renal outflow, and separately, if they are looked at, then we can target our AKI patients.
My only concern, Navina, is that this should not go in the direction of the passive leg raising. It should not go in the direction of the passive leg raising test. Now, the passive leg raising test is a very elegant test, a very useful test, physiologically robust test. But unless you understand how exactly it should be done and how you interpret the results of the PLR, you will overdo it. I think that's the main problem with Vexas. Ultrasound is a kind of a status symbol in ICU.
We are losing your signal in between, sir.
Yeah. So, is it better now?
Yes.
Yeah, able to hear.
Yeah. So, ultrasound is a status symbol. Can you do ultrasound? Yes, I can. It's a status symbol in the ICU. But can you do it correctly? You ask yourself. So, Vexas has potential for harm if you don't do it properly. So, I think if somebody who says I will do Vexas, he has a responsibility of learning the correct tool, get his findings validated by somebody who's trained in it, and then get onto the patient with the probe. Otherwise, you will do more harm to the patients. You give diuretic to somebody who's not volume overloaded, you're in for trouble. Navina?
So, Navina, the way I look at Vexas, a few years back, assessing a critically ill patients, we were limited. It was predominantly clinical judgment and clinical assessment, and which obviously could be highly subjective with a significant inter-observer variability. I think Vexas adds to the armamentarium of information and data that we can have about a critically ill patient. Just like today, when we are giving fluids, we not only look at the advanced hemodynamic monitoring, but we also do a lung ultrasound to see if the fluid is doing some benefit or harm. I think Vexas will give that extra information, which when you club with other parameters, probably will place you in a better position to take decisions on some of the very, very sick critical ill patients. But as Srinivas and Vivek highlighted, I think trainees as well as consultants, we should go through a proper learning curve, get trained to look at these, the way you are going to interpret, get the images, and use the ultrasound to get the correct Vexas.
Yeah, agree, Ghanshyam.
Yes, sir. I think for me, I think I would take away that, maybe performing a Vexas score at the bedside would be one of the parameters that I should look at for a judicial use of both fluids and diuretics. And maybe we can do better studies from our country using other variables, also putting them together. So maybe we can come with some bigger studies. And though this number was like limited, I think the sample size that they have calculated was around 85. So according to them, this wasn't like a small size to make any comments. So maybe I think we should make it a habit of checking our Vexus score as soon as we see patients developing AKI during the course of their stay in the ICU, along with the other regular lung ultrasound and the bedside 2D echocardiography that we do. Any closing comments, sir?
No, I think this is a continuum of learning, and we should keep ourselves, up to date with what's happening with Vexas. It's not fine tuned yet. A lot of, just as we now found Vexas AKI, you will probably find in ARDS. You'll also find in trauma. You may find in obstetric patients where the intra-abdominal pressure is already high, and when you get a pregnancy-related AKI, you may have to do this actually to say whether this is a hypertensive disorder of pregnancy or a hypovolemia of pregnancy. There will be multiple applications and it will only expand, so we need to keep our finger on the pulse all the time.
Thank you, sir. I would like to thank Dr. Vivek, sir, Dr. Malati for being a part of the Sixth Journal Club. The Hicks, 9th Hicks dates are actually out. Block your dates from May 10th to May 12th and register yourself as soon as possible. And we'll meet next month with a new article. Thank you all for being a part of this journal club. Thank you, Ghanshyam sir, and thank you, Srinivas sir.
Navina, Malati, you presented the paper. What are your thoughts?
We have to use this protocol in the ICU, and we have to learn and look into it, sir.
Anyway, just a word. Next month, I think the last Saturday of next month will be Criticare. So we will probably have to advance this journal club to the week before Criticare. Criticare is on the 28th, 29th, 1st, 2nd, and 3rd of March. So we may not be able to do this on the 29th of or in the first. We will do it in the last before the weekend before Criticare. Okay. Thank you very much. Have a good day. Bye bye.
Thank you.
Thank you.
Thank you, Malati.
Thank you, sir. Thank you, Malati, and thank you, Vivek, sir, once again.
Thank you, Dr. Navina.
Thank you.
Thank you, Ghanshyam. Thank you, Dr. Srinivas.
Thank you.
Thank you.